Good afternoon, everybody. I would like to welcome you to the fourth and final session of this really incredible series of webinars on occupational health. The final session is going to be on opportunities and tools to investigate occupational risk. So my name is Lisa Postow. I will be the moderator during this session. I'm a program officer in the Division of Lung Diseases at the National Heart, Lung, and Blood Institute at NIH. And I'm very pleased to welcome you to this session. So we've heard in the last three sessions, yesterday and this morning, various aspects of where the state of knowledge is about occupational risk factors for COPD and possible treatments and what we know and what we don't know. What this session is going to be is what can we potentially use to move forward to gain more understanding and knowledge about occupational COPD. So I think we'll just get started here. And I would like to invite Dr. Mazurek to speak to us. Thank you.
All right, can you hear me now?
We can, thank you.
All right, thank you very much, Dr. Postow. Good afternoon. I don't have any conflicts of interest or financial disclosures to declare. Before we discuss the research opportunities, I would like to mention two documents outlining research needs. First is the ATS-ERI's statement that highlights the types of research that leading clinicians, researchers, and patients advocates believe will have the greatest impact on patient-centered outcomes. Details of the ATS research questions are beyond this presentation. Briefly, they focus on studies that determine which outcomes matter most to patients with COPD, including the role of CT scanning, the accuracy of various tools to detect symptoms in patients at risk for COPD, the role of disease severity indices for prognosis or an assessment of potential biomarkers of disease activity, studies to relate potential phenotypic traits with response to therapy, studies examining an association between comorbidities and COPD, and studies addressing standard and novel pharmacological and non-pharmacological therapies. The second document, the COPD National Action Plan, published by NIH, provides a comprehensive framework for action. Its goals aim to increase awareness of COPD and reduce COPD burden. Goals 3 and 4 of the plan address surveillance and research. Goal 3 encourages increased and coordinated data collection, validation, analysis, sharing, and real-world application of this data as they are collected. Goal 4 aims to improve understanding of the causes and progression of COPD, the different forms of the disease, and COPD prevention, diagnosis, and treatment. So, although cigarette smoking is the most common risk factor for COPD, occupational exposures to vapor, gas, dust, and fumes plays a substantial role. Based on a review of published studies, ATS estimated the population attributable fraction for the occupational contribution to the burden of COPD at 14%. Among never smokers, the fraction was estimated at 31%. Data on occupational lung disease are available through three major systems. The national population-based systems are robust and ongoing, but collect limited information on work and exposures. The state-based case reporting offers detailed information on work and exposures. However, it focuses on selected conditions like work-related asthma. Data are also obtained from special worker populations through health hazard evaluations or an ongoing worker monitoring. In this presentation, I will discuss examples of the national population-based data sources. Population-based systems inform estimates of prevalence and burden of occupational lung diseases. The National Center for Health Statistics, or NCHS, part of the CDC, conducts the population surveys, the National Health and Nutrition Evaluation Survey, or NHANES, National Health Interview Survey, NHIS, and provider surveys. NCHS also collects mortality records through the National Vital Statistics System. Other systems include CDC's Behavioral Risk Factor Surveillance System, or BRFSS, and other public, private, and not-for-profit entities' data. The population provider survey data, mortality records are available on NCHS's webpage. These data collection systems represent the foremost sources of data. Various criteria can be developed and applied to survey data to identify persons with COPD. Feinstein and colleagues explored validity of a COPD definition based on survey participants' age, bronchodilator use, BMI, smoking pack years, and occupational organic dust exposure against spirometry testing as the gold standard for the diagnosis of COPD. The authors also examined validity of previously used definitions. The first defined COPD as self-reported physician diagnosis of chronic bronchitis or emphysema. The second additionally classified COPD as report of chronic cough and phlegm production plus 10 or more pack years of smoking. All three of the definitions showed a high specificity, but a relatively low sensitivity. Results of their studies offer guidance to researchers studying COPD in the absence of available pulmonary function testing. The NHANES is designed to assess the health and nutritional status of adults and children in the United States. The survey examines a nationally representative sample of about 5,000 persons each year. The survey is unique in that it combines interviews and physical examinations. The interview includes demographic, socioeconomic, dietary, and health-related questions. The examination component consists of medical, dental, and physiological measurements, as well as laboratory tests. Data and documentations are available for analysts on NCHS's website. Please note, the analysis of NHANES data must be conducted using the appropriate survey design. NCHS strongly encourages data users to read all relevant documentations on the survey overall and for the specific data files to be used in the analysis. NHANES datasets are organized by year. On top right is a search tool allowing for finding specific variables of interest. Here's an example of the 2017-2018 NHANES data documentation layout and instructions including web tutorial. Survey contents can be quickly examined using available chart with components by year. As you can see, the medical conditions and occupation components were administered continuously from 1999 to 2020. It is important, however, to closely examine each component by year, because over the years, some questions were removed or modified and new ones were added. Here are the questions used by researchers to identify survey participants who had COPD. During 1999-2018, 2 questions were administered relevant to COPD on a doctor-diagnosed emphysema and chronic bronchitis. In 2013, a question that specifically asked about COPD diagnosis was added. In 2019, these 3 questions were combined. Relevant component for work-related COPD is information on employment. It is available in the occupation component. The occupation component collects data on participants' work experience. However, coded information on participants' current and longest held jobs are available only for select years. In addition, NHANES administered a component on respiratory health and disease and smoking and tobacco use from 1999 to 2012. Here is an example of questions administered as part of the respiratory health and disease component. The survey collected information on the presence and duration of select symptoms, including cough and phlegm. Here is an example of questions administered as part of the smoking and tobacco use component. The survey collected detailed information on smoking habits and tobacco use. During 2007-2012, the respiratory health component included data from spirometry and nitric oxide examination. Finally, NHANES collects biological specimens for laboratory analysis to provide the detailed information about participants' health and nutritional status. In 2017, there were over 800 laboratory tests performed using NHANES biospecimens. Here are some examples of published studies on COPD using enhanced data. Two of these studies explored COPD among workers and were produced by my colleagues at NIOSH, Drs. Donny and Kurth. Another data collection system from NCHS is the National Health Interview Survey. NHIS is a cross-sectional household interview survey conducted continuously since 1957. The target population for the NHIS is the civilian, non-institutionalized population residing within the 50 states and the District of Columbia. A major strength of this survey is its ability to display health characteristics by many demographic and socioeconomic characteristics. And his data are used to monitor trends in illness, disability, health insurance coverage, and use of medical care, as well as to track progress toward achieving national health objectives. Survey data and documentation are available on NCHS's webpage. It also offers access to a summary health statistics as part of a pilot interactive data query system. Data are organized by year. Each link provides information about available files, including variable summary, layout, and frequencies. In NHIS, 3 questions can be used to identify respondents with potential COPD. During 1997-2018, 2 COPD-related questions were administered, asking about a doctor-diagnosed chronic bronchitis and emphysema. In 2012, another question, specifically asking about the COPD diagnosis, was added. And his questionnaire includes questions on employment. Here is an example of questions addressing respondents' employment status during the week prior to the interview and reasons for not working. Adult and his respondents who had ever worked are asked about their industry of employment and occupation. These data are classified by the NCHS using standardized coding systems. For both industry and occupation, major groups and detailed subgroups are available for analysis. On the right-hand side is an example of detailed industry codes. The content and structure of the NHIS were updated in 2019 to better meet the needs of data users, to improve the measurements of covered health topics, and to reduce respondents' burden. The redesigned questionnaire structures consist of 4 components: the annual core, rotating core, sponsored content, and emerging topics. The annual core questionnaire contains the same questions from year to year. These questions focus on demographic characteristics, health insurance, healthcare access and use, health conditions, tobacco use, and functionality and disability. The rotating core questionnaire consists of questions that will be included in the interview on some years with fixed periodicity. These questions focus on service utilization, preventive services, chronic pain, injuries, sleep and fatigue, physical activity, psychological distress, and allergies. Some questions on the NHIS are funded by other federal agencies. Periodic sponsored content is included in the interview in 1 or more years, but not every year. Emerging content includes new topics of growing interest that may be added by NCHS, generally for 1 year. The 2019 updated NHIS included the following question on COPD diagnosis. Have you ever been told by a doctor or other health professional that you had chronic obstructive pulmonary disease, COPD, emphysema, or chronic bronchitis? Here are some examples of recent NIOSH studies examining COPD among workers using NHIS data. The researchers examined COPD prevalence and trends among workers by industry and occupation, assess the population attributable fraction for COPD associated with work, and healthcare utilization, lost work days, and bed days. As I mentioned, NCHS also provides access to data from death certificates through their website. Mortality and other data can also be accessed and quickly analyzed using CDC Wonder, an easy-to-use menu-driven system. Through CDC Wonder, COPD deaths can be identified using the International Classification of Diseases, the 10th revision codes J40 to J44, listed as the underlying or contributing cause of death, and tabulated by various demographic variables. Here are some recent examples of studies examining COPD mortality. NCHS operates the Research Data Centers, or RDC, hosting restricted data. Through RDC, NCHS protects the confidentiality of survey respondents, study subjects, or institutions. The process and requirements for access are outlined on the RDC website. Briefly, researchers must submit a research proposal outlining the need for more sensitive data and pay a fee. Restricted use data must be accessed at a secure lab in the RDC network. On the right is an example of enhanced restricted variables available at RDC. Another data source available for analysis is the Medical Expenditure Panel Survey. It is a set of large-scale surveys of families and individuals, their medical providers and employers across the United States. MEPS collects data on the specific health services that Americans use, how frequently they use them, the cost of the services, and how they are paid for, as well as data on the cost, scope, and breadth of health insurance held by and available to US workers. MEPS has two major components, the household component and the insurance component. The household component provides data from individual households and their members, which is supplemented by data from their medical providers. The insurance component is a separate survey of employers that provides data on employer-based health insurance. In a recently published report, Dr. Simlai and colleagues reported on medical expenditures attributed to COPD among workers. Another potential source of information are the CMS data. The data include clinical claims, assessments, surveys, enrollment summary files, and other data for Medicare and Medicaid patients. CMS offers a direct access to their data that can be downloaded, viewed, and analyzed using interactive tools or access data through an application programming interface. While industry and occupation are not available in Medicare claims data, the primary payer code on a claim to identify Medicare beneficiaries who have work-related disease could be used. This code identifies a non-Medicare source, such as workers' compensation or the federal Black Lung program, with primary responsibility to pay for the claim. In a study of federal Black Lung program beneficiaries that were also enrolled in Medicare, the prevalence of COPD among Medicare beneficiaries for which the program was the primary payer was 87%, compared with 11% among all Medicare beneficiaries in 2016. Here are a few publications using Medicare data to assess hospitalizations and cost of care for COPD, as well as publications using linked SEER Medicare data to examine survival among Medicare beneficiaries. The Behavioral Risk Factor Surveillance System, or BRFSS, is the telephone survey that collects state data about health-related risk behaviors, chronic health conditions, and use of preventive services. BRFSS collects data in all 50 states, as well as the District of Columbia and 3 US territories. Each year, more than 400,000 adult interviews are completed. The BRFSS questionnaire has 3 parts: the core component consisting of the fixed core, rotating core, and emerging core, optional modules, and state-added questions. All health departments must ask the core component questions. However, the modules are optional. Questionnaires can be examined by year, state, and category. BRFSS data are organized by year and are available for download. BRFSS core sections collect data on a doctor-diagnosed COPD and tobacco use. Optional Module 24 addresses correspondence, industry, and occupation. In 2021, 20 states and Guam collected information on industry and occupation. Here are some examples of BRFSS data used. Pleasant and colleagues describe the relationship between respiratory symptoms, associated factors such as tobacco smoking, and health impairments. Fitzsimmons and colleagues examined COPD and employment among Massachusetts adults. In our study, Ms. Dodd and I estimated prevalence of COPD among workers with work-related asthma. In summary, many datasets are readily available for analysis with various variables allowing for identification of persons with COPD. Definitions can be based on self-reported doctor-diagnosed respiratory conditions, self-reported symptoms, spirometry results, or other criteria. Major limitations include limited information on the workplace exposures or respondents' industry and occupation. Researchers need to carefully examine data documentation and select data that best fit the research questions. I would like to thank Drs. Kurth, Simlay, and Henneberger for their input. Thank you for your attention.
Thank you very much, Dr. Mazurek. So our next speaker will be Dr. Ravi Kalhan from Northwestern University, and he'll be discussing the lung health cohort.
Thanks so much, Dr. Postow, and thank you all for joining today. It's really a privilege to be able to share what we're doing with the lung health cohort, which is a new cohort, which we just launched and have begun recruitment for this year. These are my disclosures. So I'm going to spend some time talking about the foundational aspects for this cohort of 25 to 35-year-olds and why we think it's so important to begin a cohort of this age group. And think forward about some ideas we've thought about impaired respiratory health, and perhaps stimulate some opportunities to think about impaired respiratory health in the context of occupational exposures. We've learned a lot over the past several years in the published literature about trajectories individuals can take towards COPD. This publication from the Tasmanian birth cohort is one of many that have highlighted that there really are multiple ways of getting towards COPD. One way is what we've sort of conceptualized over time from the days of Fletcher and Peto, that people attain peak respiratory health in young adulthood and then have a decline over the course of their life due to exposures and risk factors towards COPD. There are other groups, however, that have been more recently identified. I'm going to try to get a pointer here so that I can show you what I'm pointing out. That wasn't what I wanted. Other groups that have been identified, in particular, folks that don't attain peak lung function and have sort of a impaired respiratory health throughout their lifetime and can have obstructive lung disease. And then in addition, a group that I think is very interesting are people who have sustained below average lung function throughout their life course. And this may be associated with risk of future disease and a variety of impairments, but not necessarily cross a threshold for any particular chronic lung disease. We've replicated a lot of this work in a study called the CARDIA study, the Coronary Artery Risk Development in Young Adults study, which is an NHLBI funded cohort that was started in 1985, and really replicated the same trajectories that were identified in TAS, although they start here at age 25 rather than at birth, which is a weakness of the CARDIA study that it started in young adults, but really found similar things, that there's an accelerated decline group and a sustained low lung function group. The prevalence of obstructive lung disease, defined by our FEV1 to FVC ratio below 0.7, was highest among the folks with low lung function throughout their lives, and next highest among those who had accelerated decline in lung function. But then again, this intermediate phenotype, where people had a sustained FEV1 in the range of 80 to 90% of predicted, had a rising prevalence of obstructive lung physiology. Perhaps the lung physiology is less impressive than the prevalence of emphysema among these individuals. And we found that emphysema on a visual interpretation of CT scans was really similar to the prevalence of obstructive lung disease. The highest group from early on in the study being those who had poor respiratory health throughout their lifetime. Those with worsening lung health, as we call in this red group, had increasing prevalence of emphysema as well. And then among the preserved impaired lung health group, a rising prevalence of visual emphysema over 10 years from year 15 of year 25 to CARDIA. So we wrote a review about this. Gabrielle Liu, who's a junior faculty member in my group, and I that really thinks about the variety of exposures that can influence respiratory health across the life course. And I'm not going to name these one by one, but really just highlight the notion that there are two ways to think about this. There are those that are associated with impaired peak lung function in young adulthood, and then there are those that are associated with accelerated decline in lung function, and then there are those that are associated with both. And then there's a number of factors that perhaps we haven't really thought through in a careful way, and what their association is with respiratory health across the life course. And that's really the focus of the ALA lung health cohort, this newly formed cohort study. If we were to really conceptualize this across the life course, well, we can think perhaps about periods where we could intervene or intercept chronic lung disease. And there are periods in the growth phase where we could intercept exposures and risk factors and promote ideal respiratory health in young adulthood. And then there are ongoing exposures in adult life where if we could modify those exposures or promote health behaviors that interfered with them or intercepted them, we could promote respiratory health across the life course in a forward-thinking way. When we think about this, we really like to put it in the context of health promotion and disease interception in a frame of reference that people are used to thinking about. And the one people are most used to thinking about, it seems, is cardiovascular disease. And if one thinks about how the American Heart Association has promoted ideal cardiovascular health, it's really through two components: health promotion and disease interception. What comprises health promotion in that context? Quitting smoking, being active, eating healthy, losing weight. And then what is presented as disease interception strategies are things that are causal risk factors for the development of heart disease, controlling cholesterol, managing blood pressure, and reducing blood sugar. And it's our belief that we have not really thought about this in the context of respiratory health and what the factors that could be used to promote respiratory health or intercept a trajectory towards chronic lung disease. How could we, though, at least think about this in a way that provides some validity? What are the target populations for respiratory health promotion? And I review these because you'll see in the lung health cohort, these targets are really key outcomes for our baseline examination in 25 to 35-year-olds. You know, unfortunately, we can't ascertain the future in 25 to 35-year-olds to see whether they'll develop chronic lung disease. So we need some intermediate endpoints that we think are important, and then we're going to follow these folks forward, hopefully across the rest of their lives, to really think about this in a life course study. In Cardia, we asked a pretty simple question of whether respiratory symptoms in young adults predict future COPD and emphysema. And it turned out they did. Individuals at the baseline Cardia exam, 18 to 30-year-old, who reported respiratory symptoms were at greater risk at year 30 for obstructive lung physiology and at year 25 for the presence of emphysema. So individuals, after controlling for the covariates you see at the bottom there, who reported respiratory symptoms at mean age of 25 with a range of age 18 to 30, who reported cough or phlegm, had 1.46 the odds of emphysema at the year 25 examination on a CT scan, and 1.95 times the odds of emphysema if they reported episodes of bronchitis in their life up to age 25. So respiratory symptoms seem to be an important predictor of future lung disease and represent what we would say impaired respiratory health. What are other target populations for respiratory health promotion? Well, we thought about where someone lives and their neighborhood characteristics, in particular, an index of neighborhood deprivation using 1990 census tracts that the year 10 examination of Cardia when participants were between the ages of 28 and 40. This integrated measure looked at median household income in the neighborhood, the proportion of the population below the 150% of the federal poverty level, the proportion of the population with less than high school education, and the proportion of the population with greater a college degree or higher in terms of their educational status. And it turned out, and this perhaps is not the most surprising finding in the world, although we think it provides some important validity to what we are conceiving of, that emphysema, the odds of emphysema were 1.96 in the highest deprivation quartile for the neighborhood, as well as the emphysema, as well as the COPD prevalence on the year 30 spirometry, independent of key covariates, including one's individual income and cumulative pack years of smoking. Now, of course, socioeconomic disadvantage in a neighborhood is an integrated measure of risk and may represent air pollution and biomass fuel exposures in that neighborhood. Occupational risk factors clearly play a role based on neighborhood characteristics. Asthma, preterm birth, early life exposures and infections, and impaired lung growth, amongst several others. And these measurements in some detail are really necessary as we think about how to conceive a life course study focused on impaired respiratory health and the risk of future lung disease. Sometimes when we've presented this work, we get criticized when we think about this concept of how to intercept a trajectory towards chronic lung disease, because, you know, in the pulmonary community, we've sometimes thought of lung function decline as an unrelenting thing. We wake up tomorrow with a little less lung function than we had today. So we asked a question in Cardia just to sort of think about the construct validity of this. Are there interventions one could do to promote respiratory health? And we asked the question of whether sustaining physical fitness in Cardia from year 0 to 20 was associated with less decline in lung function across one's life in those 20 years. And it turned out that individuals who sustained higher fitness had less decline in lung function, but also people who increased their fitness over that life course. Now, this is an observational study, and there is no, trial that looks at a fitness intervention and in preserving respiratory health. But we thought this was an important finding because there are perhaps things we could apply to a target population to promote respiratory health across the life course. So our conclusion, based on that background of work, was that we really need to define and understand the intermediate phenotype of impaired respiratory health. Lung function is the most widely recognized indicator of impaired respiratory health, and the trajectory of lung function informs future COPD risk. But as many of us know, its actual measurement outside of established respiratory disease is pretty rare. And a single measurement in time, if we don't do it on a serial basis, is not really informative about a life course trajectory. If someone's FEV1 is 90% predicted at age 30, we don't know whether they had impaired lung growth throughout their lifetime or they had an insult sometime in the antecedent few years, which resulted in lower lung function. And understanding the trajectory seems important. So we think biomarkers of impaired respiratory health would allow for more efficient identification of at-risk individuals, provide mechanistic insight into susceptibility versus resilience, i.e. lung health endotypes, and provide the framework for interception of COPD and other chronic lung diseases. We sometimes say we really need to find the cholesterol for the lung, so perhaps we should think about why is cholesterol so good? Well, it's so good because it's easy to measure. It happens everywhere. It predicts atherosclerosis and coronary heart disease events. And perhaps most importantly, it's on the causal pathway for the disease it predicts, and it can be modified with therapies. And I would say, can we do this in respiratory disease? Well, I don't know, but we certainly have not tried in a thoughtful way, and we need to start focusing on this concept so we can find targets for interception, and that's really the priority of the lung health cohort. One of our key outcomes in this baseline exam is CT scan imaging and what we call CT lung injury. I'll highlight that because we really think the potential of radiographic imaging to define future lung disease is really important. George Washko and Raul San Jose, who are part of the leadership of the LHC, really have pioneered this work using CT scans to create what one could conceive of as a lung health map, where using automated features, you can really identify various forms of abnormality on CT scans. And I just want to call attention to one area that are visually normal areas of higher attenuation, which we term CT lung injury. When you look at CT lung injury, and we derive some of this work from Cardia, the percentage of parenchymal lung injury on a CT scan is associated with a 10-year period with greater risk of future emphysema as well as interstitial abnormalities on a CT scan performed 10 years later at year 25. So perhaps that early injury is reflective of future lung disease. So we've conceived of this as a way through this paper, which George and Raul led along with folks from their group, Roland Harmouche and Sam Ash, that you could really combine automated features on CT scans, areas of high attenuation, using automated densitometric methods as they are characterized as a point in time that represent an unfavorable trajectory towards disease, be that pulmonary fibrosis or visual emphysema. And then interestingly, we don't really know, perhaps there are some people who resolve that injury through modification of risk factors, changes in exposures, or perhaps health promotion activities. A little bit more about CT lung injury and blood biomarkers. Well, this CT lung injury in individuals from COPD gene, as well as the Pittsburgh Plus cohort, was associated with higher levels of systemic inflammatory markers, C-reactive protein, and ICAM1. And it turns out that those same systemic inflammatory markers in cardia, when measured at year 7, were predictive of future COPD. And maybe there's a story to be told about integrating individuals with CT lung injury with biomarkers of risk to think about them in the context of future lung disease and their risk. So life course studies are really critical to inform both prevention and interception strategies, and asking key questions about how do responses to environmental, occupational, and behavioral exposures differ across the lifespan, and how can we use those variable responses to identify target populations to target health promotion efforts? What are the critical periods and time points for avoidance? How does the age of exposure influence resilience? And what interventions actually improve resilience? And then importantly, I think, how can we focus our efforts on biomarker discovery to identify respiratory health endotypes as a framework for disease interception? Really thinking through whether or not we can find mechanistically informative biomarkers on a causal pathway that allow us to intercept chronic lung disease before it's clinically apparent. So the ALA lung health cohort is an NHLBI funded study of healthy young adults conducted in partnership with the American Lung Association using their Airways Clinical Research Centers platform. That's advantageous. It allows us to conduct this study in 29 metropolitan areas among 25 to 35-year-olds, and we're currently enrolling in the baseline examination. The overarching goals of the lung health cohort are to inform the divergence between respiratory health and disease through identification of risk factors and exploration of pathobiologic pathways that drive the transition from health to chronic disease over the life course. We are doing a baseline exam right now, so we have some short-term goals to ask questions such as, what is the relationship between a variety of exposures, pollution, vaping, secondhand smoke, behaviors, physical activity, as well as things like occupation, and biomarkers and peak respiratory health in young adults, because these folks, remember, are between the ages of 25 and 35. And then our medium and long-term goals are really to determine factors that influence the divergence from ideal to impaired respiratory health. Who ends up on that intermediate phenotype to chronic lung disease from young adulthood forward, and the pathobiologic pathways implicated in that process. And ultimately, like we talk about, to find the cholesterol for the lung. The phenotyping protocol entails a detailed set of questionnaires. Spirometry, we actually have ended up only doing pre-bronchodilator spirometry in these folks to minimize burden at this point. We are collecting serum plasma and urine, a blood PAX gene RNA tube, and a cellular pellet for DNA. We collect nasal absorption strips to collect nasal epithelial lining fluid, as well as a nasal curettage to get cells to do gene expression analysis on. We have a CT scan, both inspiratory and expiratory. Spirometry is complemented by then home spirometry, where individuals do it over a 5-day period for 14 days to get used to the idea. We can compare that to the in-clinic spirometry, and then they would do this quarterly going forward at interim contacts. And then we have a 7-day actigraphy monitor to measure physical activity. The domains of the questionnaires are listed here. We really focus heavily on the ATS-DLD respiratory questionnaire, as well as a modified rhinitis symptom utility questionnaire. We have detailed questions about substance abuse and environmental and occupational exposures. I had hoped we could share those questionnaires by sticking them in the chat function on Zoom. Apparently that's not possible, but certainly I could be emailed for them and we can share them through another way and follow up with anyone who's interested in them. The occupational history is focused on the things you would expect it to be focused on. The type of activity at work, sitting, driving, standing, manual work, etc. The job title and location, and then we have a list of job categories, which we're glad to share. And then there are detailed questions around exposures, vapors, gas, dusts, and fumes. And then I am glad to share that data collection form to stimulate any ideas or thoughts towards ancillary studies that anyone would like to perform in the lung health cohort. We are by all means looking for collaborators and an expansion of how we can collect information in the LHC. Ancillary studies are a high priority for us, as well as sort of career development projects for junior folks, and we're eager for partnership. So please don't hesitate to reach out if there are things you think you would like to do in partnership with the lung health cohort. I'll mention as well that while this is very much a city-based study, most of our measures are carefully aligned and harmonized with the rural cohort, which Dr. O'Connor is going to talk about right after me. So there are probably opportunities to think about both of those studies in combination in the context of ancillaries. With that, I'll stop, and thanks so much for your attention.
Thank you very much, Dr. Callahan. That was great to get an overview of the lung health cohort. So next, as promised, we are going to hear about a second study that's just starting up, the rural study. And for that, I invite Dr. George O'Connor to come and tell us about it. Dr. O'Connor? We may be having some technical difficulties with Dr. O'Connor, so
he appears muted.
okay. So while Dr. O'Connor is getting set up, Dr. Pollan, would it be possible for you to speak now, and then we could come back to Dr. O'Connor?
Yep, that's fine. I'm happy to go.
Okay, great. All right. So fantastic. So Dr. Pollan is going to now discuss with us the spiromic study and some work that she has done with that. And then we'll come back to the rural cohort when the technical difficulties are solved. Thank you.
Can everybody hear me?
We can.
Yes, very
Yes.
well.
Okay, so your slides.
Thank you. Thanks for coming today. My name is Laura Pollan, and I'm an adult pulmonary critical care physician at Dartmouth in New Hampshire. And I had worked with Nadia Hansel on spiromics quite a bit when I was at Hawkins, and still work with her on several collaborations. So you may notice her name on the agenda, but she had asked me to share some experiences that we've had with the spiromics cohort, and specifically looking at occupational exposures in spiromics. I have no conflicts of interest. I'm going to briefly describe spiromics as a cohort study and specifically look at how we look at occupational exposures in spiromics, and show some examples of how we use the questionnaire data for certain publications. So spiromics, as you can see here, subpopulations and intermediate outcome measures in COPD. There's a multi-center cohort study with several sites around the country listed here, and several clinical subsites. The goal of spiromics was to really identify intermediate markers of COPD that were linked to meaningful clinical outcomes in an attempt to kind of move up the timeline of clinical trials and therapeutics, and identify subgroups and endotypes of COPD patients who may or may not benefit from certain therapies. and echoing a lot of what we just heard with the lung health cohort as well. Enrollment criteria was based on the 4 categories that you see listed here. There was a small group of non-smoking controls that were recruited. However, the bulk of Spiromex participants were individuals with a heavy smoking history of greater than 20 pack years of cigarettes. And those were divided into people with and without airflow obstruction, based primarily on fixed ratio. And then the individuals with obstructive lung disease were broken down to mild, moderate, and severe COPD is listed here, with the recruitment goals listed on the last row there in that table. And individuals had a baseline visit and were followed yearly for 3 additional visits. So this is an observational longitudinal study. And at each visit, there was extensive phenotyping of the participants with physical exam, biospecimens, including sputum, blood, serum, urine, and a sub-study that looked at bronchoscopy where BAL was collected. In addition to that, radiograph was done for quantitative CT imaging and a whole host of questionnaires that looked at quality of life, symptoms, depression, functional status, et cetera, and also extensive exposure questionnaires, which we'll get into more closely. In addition to those clinical visits, there were quarterly follow-up phone calls to ask about exacerbations that happened in the meantime, and also to assess general health status. And at these phone calls, and mortality data was collected as well. And for this first round of Spiromex, nearly 3,000 participants were enrolled and followed. And as I mentioned, multiple sub-studies and ancillary studies that further enriched the data collected in the general cohort. And if we have time, we'll talk about one of the air pollution studies that I've been involved with. So Spiromex 2 was an additional study that extended the longitudinal follow-up to include an additional visit that occurred 5 to 7 years after the baseline visit. And this really used the data collected in Spiromex 1 to identify some additional aims for Spiromex, basically identifying factors that were associated with disease exacerbation and progression, trying to essentially, like as mentioned before, find the cholesterol of the lung in essence. And then again, to try to identify targeted approaches to COPD treatment. And briefly mention SOURCE, which is just starting, which is looking at early COPD progression. So this is in a younger cohort of a younger age group than what was previously shown for the initial Spiromex. So for the occupational questionnaire exposure assessment, there's an employment history form which has been asked at each visit, starting the baseline visit, and has been asked throughout Spiromex 1, Spiromex 2, and then some modifications, and will also be asked in SOURCE with the younger population, which is really exciting because there's going to be a lot of exposure, occupational exposure data. In current employment and status is assessed at each visit. You can see here, this is just a snippet of one of the baseline forms that asks specifically if you're employed for a wage or salary, part-time or full-time, and you've ever been employed for a wage or salary. And then there's a bunch of skip patterns that kind of walk the participant through. And this is guided with a research coordinator. So they're kind of stepping through this process with the participant. Questions are asked about the last job the participant had, the longest held job, and their current job. And depending on what people answer, some people will have one job for their entire career. So this is all the same job, but the skip patterns help identify which job we're talking about. Reasons for leaving prior jobs are asked. The duration of exposures at certain jobs or the time that you worked at a job are assessed. And then there are details about specific exposures and trades that were asked. So several of the questions kind of get at different things in the exposure questionnaire. There's a self-report of exposure to vapors, gas, dust, or fumes. And again, this is asked at current job, prior job, and longest job. Yes, no, don't know. And then there are self-reports of specific jobs where they're just simply asked, what was your occupation at this job? Again, current, last job, longest job. In addition to these open-ended questions and the specific questions about VGDF, participants are asked if they've ever worked in certain locations, as you can see here, and the years at each location is assessed. Participants were also asked if they worked in specific trades as listed here. And I should mention that this questionnaire was developed in the early stages of Spiromics development, and input with Mark Eisner was one of the primary persons who worked on this. And these were kind of developed as the study was being developed. This was before my time with Spiromics, but I just wanted to give credit to the team that made this questionnaire. And certain exposures were asked specifically. Do you come into contact with any of the following specific examples of vaporous gas, dust, or fumes? And you can see the listings here. So on follow-up visits, to avoid burden to the participant, these questions are only asked again if the participant notes that there's been an employment change in the last 12 months. For Spiromics, one of the visits were separated by 1 year, so it says the last 12 months. In Spiromics 2, there could have been a delay since the last visit that was longer than 12 months, so it's asked since your last Spiromics visit. So just some minor wording changes between the studies. But if they did note that there is a new change in employment, the questions and the skip patterns go to why they left the last job. And this could be simply because they retired, or else maybe they left from a health concern, and we capture that in this questionnaire as well. So how do we apply these methods? And these are a few examples that have come out of Spiromics that really show how this questionnaire can be used in a variety of ways to pinpoint that occupational exposure. And this is one that we did on the baseline visit of Spiromics that looked at about 1,100 people who had a heavy smoking history, about 700 of which had COPD. And we looked to see if occupational exposures were associated with COPD prevalence and also outcomes within COPD. And how we looked at this is we did 2 different exposure assessments definitions. The first one using that simple question that I mentioned earlier. Have you been exposed to vapors, dust, gas, or fumes? And we chose the longest job for this one. And the benefits of using this tool is that it's a very simple question. It's yes, no, longest job. There's not too much to think about. You just say yes or no. You don't have to know the specific details of what it was, but were you exposed to one of those 2 things in the VGDF? The backside of this, obviously, is that there could be some recall bias. People may be more incented to report, yes, they did have an exposure if they're concerned about their health, or if they've kind of self-selected themselves to enroll in a study about COPD. We also use these data to use a job exposure matrix to assign risk to the occupation that the participant wrote down. And you remember that free text entry, what was your longest job? And they write an occupation. And so we worked with Paul Blank on this to use his COPD specific job exposure matrix to assign an intermediate, low, intermediate, or high probability of exposures relative to COPD based on that job. So each job was coded into a census code, and then that census code was referred to in the GEM and assigned a risk of 0, 1, or 2. The advantages of the job exposure matrix, it avoids subjectivity of the self-reported exposure. So the person is just simply listing their job, and there's very little opportunity for bias in terms of what they write. The backside is it is labor intensive to actually go through the GEM process. And the other thing to note is that people may not be as descriptive as you would hope when they write down that occupation. And different industries, even within the same job title, can have very different exposures, depending on whether or not you're wearing PPE, where you are in an assembly line, and what the day-to-day flow of the industry might be. So we looked at both of these to look at COPD prevalence, and we found that when using this GEM, those who had an intermediate or high risk of occupational exposures that were relevant to COPD had increased odds of COPD by a factor of 1.44 compared to those with low on the GEM. We did the same thing for yes, no VGDF and found that there was an increased odds of COPD of magnitude of 1.37. And again, this was adjusted for pertinent socio-demographics and smoking history, both current smoking status and past years of smoking. And overall, in these results and the outcomes, the additional outcomes that I'll show next slide, there was very good agreement between the GEM and the VGDF question. And you can see here that the intermediate high risk exposure folks had on average worse outcomes across the board compared to those with low risk of exposure, even when accounting for a very heavy smoking history. And even among people with a very heavy smoking history, reminder that there are no non-smokers in here. So this is kind of above and beyond their smoking history, current smoking status, and pack years. And just briefly looking at this table, lower 6-minute walk distance, higher dyspnea, higher CAT score, worse quality of life, lower physical health, and an increase in severe exacerbations. We also used the occupational exposure questionnaire to look at quantitative CT imaging, which was introduced in our prior talks. I won't spend too much time on that, but basically we can estimate and quantify the amount of emphysema, large airways disease, and small airways disease in spiromics due to the extensive radiographic phenotyping that's done as part of the study. And we use that simple VGDF question to look at the relationship between occupational exposures and these quantitative CT outcomes. And we found, again, across the board, even as after you account for smoking history, that the occupational exposure was associated with a higher percent emphysema, increased wall area percent, which is a marker of large airways disease, narrower airway lumen, and increased air trapping representative of small airways disease. So this was another way that we used this questionnaire data. We also have something in the works that I've been working on with a DRPH student. This was her dissertation thesis. She's an industrial hygienist as background, and she basically went through all of those specific trades, locations, and exposures to group them into different categories that may be relevant to human health. And you can see the categories that she grouped them into. People could end up being in more than one category, so they're not mutually exclusive. But she looked at those separate groups as independent predictors of COPD morbidity. We also took advantage of looking at the duration of exposure to see if we could come up with an exposure year predictor associated with worse COPD outcomes. And then she compared the magnitude of these findings to that yes/no VGDF question that we're familiar with. And so what she found, and this is kind of under review now, and we haven't published this quite yet, but there are some groupings that actually show a higher magnitude based on the effect size, more so than using the VGF measure, suggesting that while the VGF measure is a great one and it lines up with the GEM, we may in times be underestimating the occupational risk of certain exposures. And we also are looking at this duration and found that when you look at each additional year of wood dust exposure, that was associated with a lower FAV1. And this was a cross-sectional analysis. So whether or not this pans out longitudinally, we're not quite sure yet, but we will have the ability to look at that. And an increase in small airways disease by the quantitative CT findings. One thing, if I have a little bit of time, I did want to share one of the ancillary studies that is part of spiromics that really leverages the rich phenotyping that's part of spiromics. And this is called Spiromics Air. And what we were able to do with this study is to use the geocoded address of each spiromics participant to estimate the the pollution exposure that's happening at that address. So this is just another way, additional way to quantify the exposures that might be relevant to COPD morbidity, in addition to occupational exposures. And what's really great is that we're able to look at potentially the interaction between occupational exposures and air pollution, and how these both play out in terms of looking at multivariable analysis over time and seeing how they interact and how they influence each other. And so Spiromics Air used a method developed by team members at University of Washington who used in MESA, they predicted air pollution exposures in MESA participants. So a lot of it is the same modeling approach, using an extensive spatiotemporal prediction model that uses geographic data, land use data, satellite imaging, and also real-time monitors that are both EPA sponsored, regional sponsored, and then our own study that enriched these exposure assessments to estimate what's happening outside of people's homes, and then also looking at their time activity and their indoor sources to estimate what's actually happening in their homes. And depending on where people spend their time, most of Americans are spending at least 90% of their time indoors. We weighed the balance of where they're located to come up with an exposure prediction for each participant. So this is really, really well defined and well characterized exposure data. And we can estimate this on a 2-week exposure history, 1 month, 1 year, out to 5 or 10 years based on where that person lived. And Spiromics did capture when people moved, so we were able to kind of look back at prior addresses to see if how that pollution data changed based on their history. And these are just some pictures of getting supplemental monitoring. We did a indoor air monitoring campaign and also some community monitoring. And this data fed into the model predictions. We also looked at all of these different variables, as I mentioned before, that went into the models. And you can see what this looks like. This is in Baltimore. And these were Spiromics participants, each triangle. And you can see that the lower NO, this is nitrogen dioxide concentrations, where the lower concentrations in green and the red concentrations are higher NO2 concentrations. And you can see that there's a lot of variability, spatiotemporal variability. So this model is very refined down to the actual address. And the benefit of this over using like a fixed monitor that EPA did is that you might have one monitor in the city, and that's going to tell you the same air pollution concentration for all the people in your one city, even though we all know that it varies highly based on space and time. So this allows for that really discrete measurement of air pollution. And so we were able to use these data to show that long-term ozone exposure was associated with worse outcomes in Spiromics participants. And again, this is kind of across the board. This is a busy table, but worse CT measures, worse quality of life, more symptoms, more dyspnea, and increased exacerbations. And again, this was accounting for their individual smoking behavior, their job exposures, and other pertinent sociodemographics. So really excited about these ancillary studies that Spiromics offers. So in general, we learned about Spiromics. We know how we're asking about occupational exposures and how we can use that tool in multiple different ways, and how we're actually able to leverage all of the different Spiromics ancillary studies to further look at individual exposure history and COPD outcomes. So I'll stop there, and long list of folks. The names here listed are mostly the Spiromics Air folks. It's not exhaustive of all of the Spiromics investigators, which are many throughout the country. So thank you.
Okay, great. Thank you so much, Dr. Pollan. And during your talk, we were able to fix some of the technical difficulties that we were having with Dr. O'Connor. So without further ado, I think Paul is going to share the slides, and George will be able to give his presentation. So again, this is Dr. George O'Connor from Boston University, and he will be discussing another cohort that is just starting up the rural cohort study.
Hello, can anyone hear me?
We can, yes.
Okay, well, I apologize.
Excellent.
I was saying to people as we were trying to sort this out by email, I do Zoom multiple times per day in terms of screen sharing and never have a problem with it. And for some reason, your system is just not working on my computer. So I don't know what's going on with it. But I phoned into the system, and if you can hear me and Paul can advance the slides, we can probably proceed.
Yes. Just
All right.
let me know when to advance them, George, and I'll do.
I
do
will.
that.
Well, so thanks so much for inviting me to participate in this really interesting webinar on occupational risk factors for COPD. It's a pleasure to be able to tell you about the rural study. I'm George O'Connor from Boston University School of Medicine, where I direct the pulmonary core for the rural study. Paul, next slide, please. And a couple of disclosures, none of which are relevant to today's discussion. Next slide, please. Okay, so the rural study, this stands for the Risk Underlying Rural Areas Longitudinal Study, and this is funded by the National Heart, Lung, and Blood Institute. And as Dr. Kalhan mentioned earlier, we're just getting underway with our baseline examination as the lung health cohort is, and we've been trying to coordinate a lot of our data collection with the lung health cohort so that there's some harmony between the data being collected by the two studies. Next slide, please. And this is a large nationwide undertaking involving investigators at many universities, as you'll see listed here, involving different cores and parts of the study. Our fearless leaders are Vasan Ramachandran, who has been at Boston University until just recently moving to the University of Texas at San Antonio, and he will remain one of the multiple PIs. The other two multiple PIs are Suzanne Judd at University of Alabama at Birmingham and Paul Targonsky at University of Virginia. And you can see the various other cores and boards and so forth that are involved in the study. I'm not going to go through the whole list. Next slide, please. So just a little bit of background then in terms of the rationale that motivated the start of this study and the funding of the study by NHLBI. People living in impoverished counties in the rural South have lower life expectancy, the lowest life expectancy in the U.S., and the highest mortality due to heart, lung, blood, and sleep disorders, et cetera. This southern rural mortality penalty has worsened over the last 2 decades. It does not spare any race or ethnicity, and it persists even after adjusting for poverty. It's accompanied by a health span penalty, a greater burden of risk factors that shortens the healthy lifespan and morbidity due to chronic disease. It's felt that unhealthy behaviors in social and environmental factors may account for much of the excess deaths in the rural South. The context and places where people are born, live, work, and age are powerful predictors of their health and can render entire communities vulnerable to clusters of chronic health problems. So this is some of the underlying observations and rationale for choosing this particular population to launch an epidemiologic cohort study. Next slide, Paul. So the goals of rural are to elucidate the multifactorial basis of the rural health penalty in the American Southeast. We will identify, sample, recruit, and retain a rural multi-ethnic cohort of approximately 4,600 participants in 10 rural South counties in 4 states, Kentucky, Alabama, Mississippi, and Louisiana, characterizing a broad range of exposures across multiple domains, both at the individual and the community level, in rural participants, and illuminate how these exposures relate to risk for diseases of the heart, lung, blood, and sleep. Next slide, please. Now, this is a busy slide, but I just want to mention where we are going to be recruiting these participants. We started in Dallas County in Alabama in the first row. We're now onto Wilcox County in Alabama. And you can see there are going to be 4 counties in eastern Kentucky, really very much in eastern Kentucky coal country, 2 parishes in Louisiana, and a couple of counties in Mississippi. This is a busy slide, but if you go on to the next slide, I just want to show the same slide, but bringing a couple of things to your attention in terms of the design. So we're going to be recruiting participants between the ages of 25 and 64. Our initial plan was to actually start a little bit older than that, but in collaboration with the lung health cohort, Ravi Kalhan and his colleagues, realizing that they were focusing on individuals aged 25 to 35, we decided to lower our lower age limit so that we would have some overlap between our age range of our population and theirs. They're obviously studying, as Ravi explained, individuals who are at their peak of lung health. We want to include individuals at their peak of lung health and then beyond that as they age up into age 64 on entry into the study. So that's one aspect that I wanted to point out on this slide. Also in the lower right-hand corner, you see that sample size goal of 4,600. So we hope that our ultimate sample will be approximately 4,600. It may turn out to be a little bit lower than that, just having to do with slow recruitment, in part related to the pandemic and getting a slow start. The other thing I wanted to point out is that the choice of these counties and parishes is not completely random. We've tried to pick counties, or in the case of Louisiana, they call them parishes, that have high risk or low risk of mortality and morbidity. And in particular, what we've tried to do is pick then high and low risk counties that have similar composition in terms of race and ethnicity. So for example, if you look at Assumption Parish and Franklin Parish in Louisiana, Assumption being a low risk parish in terms of health outcomes, Franklin Parish being a high-risk parish. But you look over at the far right of that yellow box, you'll see they have a very, very similar percent of white participants, black participants, Hispanic participants, and other participants. Those are the four numbers in each row there. So we have a high-risk parish, a low-risk parish with similar racial ethnic composition. And this was deliberate, and you'll see this in some of the eastern Kentucky counties and as well as the Mississippi counties. Our two counties in Alabama are both high-risk counties. I think, frankly, we were not able to find a rural, low-risk county in Alabama that balanced them to be able to do that design in Alabama. Next slide, please. Now, our sampling frame is started out with the approach that it would be probability sampling, that would be a true population-based sample, drawing on lists of voters and so forth in the population, and then inviting households to participate in a truly population-based sampling way. We've found that enrollment has been slower than we'd hoped for, and in order to try to meet our enrollment goals, then we've adopted a hybrid approach of probability-based sampling with convenience sampling. In other words, inviting volunteers to join the study rather than a purely population-based approach of reaching out to specific households based on the population sampling scheme. So again, a combination of probability-based with convenience sampling. And ultimately, when we get to the point of data analyses, we will be adjusting for the proportion of the sample, which is convenience sample of volunteers who are interested versus probability-based sampling. We are having some success with multiple modalities of recruitment and study messaging, but obviously this is always one of the biggest challenges with a new cohort study is interesting the community, getting them engaged, and getting people to sign up for a cohort study that involves a fair bit of expenditure of their time. And I want to go on to the next slide, please. Paul, oh, thank you. And so we're doing community engagement and social media. It's a picture of Dr. Irvin Fox in Jackson, Mississippi, down in the lower right there. We're reaching out to engaging the community with community advisory boards in every community in which we enroll. We are trying to streamline the protocol so that once we roster someone, that is to say we contact them, we get them interested, we try to relatively quickly get them to our MEU, our mobile examination unit. I'll show you a picture of that in a minute. So that we don't lose their interest between the time we first contact and they expressed interest and the time we get them in there. Finally, we've also reached out to a commercial company, Precision Opinion Incorporated, to help us with the outreach to potential participants in the community with phoning and so forth, to try to streamline and improve the efficiency of our recruitment strategy, so we can reach out to many people quickly and try to get people enrolled. We do have kind of a fairly stringent enrollment timeline, because our funding goes over a certain number of years. We have to go from one county to the next, so we can't linger too long in any one county without falling off of our timeline. Next slide, please. Okay, now in terms of rural data collection, this is just a partial list of the data that we're collecting, and I've highlighted in red things that are relevant to occupational exposures and to chronic obstructive pulmonary disease. The first part, which is computer-assisted telephone interview, screening and rostering, that's where, having reached out to households and invited them to participate, when we then make contact with someone who is interested, we start with a computer-assisted telephone interview, get basic information such as date of birth, race, ethnicity, gender, educational status, and so forth. Then we have a baseline telehealth visit, which now will include medical history, including respiratory disease, and some standard questionnaires similar to the ones that Dr. Callahan mentioned are being used in the lung health cohort. The behavioral history, including smoking history, employment status and general occupation information, residential history. We then go on to a mobile health part of the study, which involves providing participants with a smartphone, unless they have one of their own that they wish to use. And now there are a number of other questionnaires and surveys and so forth that are part of that mobile health module, including marijuana and recreational drug use, secondhand smoke. There's a sino-nasal questionnaire, a job stress and occupational hazards questionnaire, many other surveys related to social determinants of health. And so you can see the list of some of the things there. Finally, we get to the mobile examination unit, which again started in Dallas County, moved on to Wilcox County in Alabama. And sometimes I describe this to folks as sort of like the Framingham Heart Study on wheels. Anthropometry, blood pressure, medical history, medications, blood and urine collection for biomarker research and genetics, electrocardiogram, thoracic CT scan suitable not only for coronary artery calcification, but lung image analysis, echocardiography, spirometry, plus post-bronchodilator spirometry if the baseline is abnormal, ankle brachial index, dietary assessment, healthcare utilization, other social determinants of health. So again, we go from that initial computer telephone interview all the way to the half-day exam in the mobile examination unit. Next slide, please. And here is a picture of the mobile examination unit parked in Alabama. And obviously, we have to hire a huge truck to drive this trailer from place to place. This was built specifically for the rural study and designed to accommodate the various study aspects. It's not just an empty trailer, as you're guessing. Next line, please. And some of the things that are inside that trailer are, on the left, a CT scanner to do the thoracic imaging. There's a laboratory in there where we do the preliminary processing of the blood and urine samples that are obtained. Over on the upper right, you see our spirometry station and some more of the lab components below that. And our current team in the MEU in Alabama is pictured there. They've been doing great work, seeing typically between 4 to 6 participants per day in the MEU. Next slide, please, Paul. For spirometry, we're using the Ezion PC, which is from NDD Medical, very portable spirometry device that's been used by many epidemiologic studies. I think a lot of people on the call will be familiar with it. Next line, please. Now, in terms of occupational questions relevant to this question of occupational lung disease, I wish I could tell you we had more extensive occupational data than we do, but we have fairly limited occupational questions from my point of view. And we ask about the current job and which of the following best describes your current job, and you can see there are a number of categories there. How long have you been in that current job? But we don't ask a detailed occupational history that goes back over multiple jobs. We don't even have a question right now that deals with the job you have longest held. So this current job could be something that the participant has just been doing for a year, leaving out their whole prior occupational history before that. And unfortunately, at this point in time, our occupational questions are fairly limited. Next slide. There's also a questionnaire that's described as occupational hazards, but that one is also, from my point of view, fairly limited. There are a number of questions having to do with how stressful you find your job, do you have job security, shift work, working overnight, et cetera. But in terms of the actual job that you do and the particular inhalational and other exposures you may be exposed to, we have relatively little data. So for example, we're asking whether the air in my work area is clean and free of pollution, yes or no? Well, it's a fairly vague question by my way of thinking. I'm well protected from exposure to dangerous substances. The overall quality of the physical environment where I work is poor. So these are some of the kinds of questions in this job hazards questionnaire, but fairly limited from my point of view. Nothing like, unfortunately, we have nothing like some of the very detailed occupational history questionnaires that NHANES has asked in the past, which go over multiple jobs in one's history and exactly what one's work was, and exposure to various inhalational exposures in that job environment. So right now we have fairly basic, again, occupational questions. Next slide, please. Now, after the mobile exam unit visit, there are some other aspects of the study. Participants are asked to wear a Fitbit on their wrist for 6 months to track physical activity, health data, sleep patterns. They're asked to periodically answer questions about life and health using an app that's called My Data Helps. So this is all part of the mobile health follow-up. Annual follow-up phone interview to ascertain health-related events and outcomes. When we ascertain that a health event has occurred, we obtain health records, electronic health records and so forth, or paper as needed, to follow up key outcomes. And then those outcomes will be adjudicated in a formal process by clinicians who will review those records and to adjudicate those key clinical outcomes. Next slide, please. Now, I want to talk about the rural ancillary studies because we, from the outset, have been very anxious to encourage ancillary studies to be added on to the rural longitudinal cohort study. So on our website, there's a whole page about this. There's a formal application process to register and then log in, create an account, to file an application to submit an ancillary study if one wanted to do an ancillary study added on to rural. Next slide, Paul. And so far, 2 ancillary studies have been approved and funded by NIH. One is epidemiologic determinants of cardiac structure and function in rural residents. This was basically the ancillary study that added echocardiography onto the study because it wasn't part of the core protocol. And then another one from Dr. Mahassan Mujahideen is neighborhoods in cardiovascular risk and resilience in rural communities. So these are 2 ancillary projects that have been not only approved by the Rural Steering Committee, but have subsequently been submitted as grants and funded by the National Institutes of Health. Next slide. Now we're collaborating in collaboration with other investigators. There are a number of other ancillary studies that have been approved by the Rural Steering Committee and have been submitted for funding to NIH, but have either still under review or have not been funded in the initial go-round. One of those particularly interesting, relevant to today's discussion, is lung CT and metabolomics. And George Washko, who we've been hearing referred to today for his work on CT lung imaging, and Meilan Han at the University of Michigan are both involved in that application. So that one is still in the works, and we're hopeful that that is going to ultimately succeed. Even though that is not yet funded, George Washko has been involved with our CT acquisition algorithm, working with Matt Budoff so that as we're acquiring CT data for cardiac imaging, for coronary artery calcification and so forth, we're making sure that the data, the images are acquired in a way that will be suitable for lung CT image analysis. We're also working with Susan Redline and Dan Gottlieb and others on an ancillary study looking at sleep-disordered breathing and sleep in the setting of the rural study. Next slide, please. So this is my final slide, just sort of summarizing the occupational and respiratory health outcomes in rural. We, like some of the other studies we've heard about today, we have respiratory disease history, symptoms, thoracic CT suitable for lung image analysis, and spirometry. These are all data that are being collected. We have only limited occupational history being collected, however, at the time. I think a more comprehensive occupational history would require an ancillary study. It's a ancillary study proposal and funding and approval by the steering committee were we to try to add a more comprehensive occupational history questionnaire that would get at you know, the entire history of one's occupational life and exposures. So I'll stop there and turn it back over to Lisa.
All right, thanks. Great, that was fantastic. So I would like to thank all of the speakers this afternoon. And I'm going to take a page from Dr. Tom Croxton's book from yesterday. And instead of having two question answer periods, I will open up the question answer period to those who spoke in this last session and those who spoke in the morning. We do have joining us Dr. Carlston and Dr. Karadman from earlier today. All right, great. So thank you again. So we're going to open this up. If anybody has any questions, you can please put it into the Q&A. But I will get things started, and I guess this is sort of a big question, and I don't expect anybody to have an answer to it. But this morning we, heard about all of these different mechanisms for how occupational exposures could potentially be leading to COPD, and Dr. Karadman in particular spoke about exposure to nanocarbon black, which is basically a stand-in for sort of combusted material. However, when we talk about occupational exposures, very often we talk about vapors, gases, dusts, and fumes. Those are not all combusted materials, clearly. So I guess my first question is, and you can either answer with something that you know or hypothesize, or with potentially how we could get at the answer. But are there expected to be different mechanisms for these different exposures? Do we think that vapors, gases, dusts, and fumes lead to COPD? Dr. Paulin, I know, had some data suggestive that the particular exposure was important. But does anybody have any thoughts on that question, or how we could try to answer it? Could there potentially be different mechanisms all leading to COPD from these different exposures?
I guess I would say I bet they're more similar than different, but still different. I mean by that not to be simplistic, but I think oxidative stress is a very widespread and powerful mechanism for a lot of this. And I guess I'm not alone in that, because it sounded like Dr. Barnes was generally in agreement with that statement. And related to your question, Lisa, the inflammatory gases and particle-rich aspects of occupational exposures are both known to be oxidative. Obviously not every single exposure in every single circumstance, but there's common there's commonality in the oxidative stress pathway between gases and particles. So in that sense, I'm saying similar, but other aspects are really different. You know, the allergens are part of the particle mixture, even though people don't really think of it often that way. But if you collect a bunch of particles, you're going to be collecting allergens, as well as more carbonaceous stuff. And the allergen pathways are obviously quite different and more of an adaptive immune pathway. So there's an example of a distinction, whereas allergens don't really present in the gaseous form per se. So not a great answer in the sense that it's not definitive, but as you said, there's not likely to be a clear-cut answer, and that's my perspective.
Right.
Can you hear me, Lisa?
I can, George, go ahead.
I was gonna, make the same point that Dr. Carlson nicely made. Of course, dust includes coal dust in eastern Kentucky and red western cedar dust from working in a sawmill. And these things are going to, very different mechanisms of affecting the lung. Yet, in response to the simple question, have you been exposed to dust in the workplace? Both, workers might say yes, but the red western cedar dust exposed worker is an adaptive immunity mechanism with, asthma and chronic allergic airway inflammation, which may lead to chronic obstructive lung disease. The coal dust, obviously, something quite different. So, I think there's potentially a lot of heterogeneity in what simply gets, included under the question of the VGDF.
Yeah, this is Laura. I was just going to echo the same sentiment that George just said. Like, it's a good question in using these big studies where participants have a lot of burden of other questionnaires, and it's almost like a screening question. Like it kind of lumps everything together, but it really doesn't allow for specific mechanisms. And I think that there is an opportunity to ask follow-up questions, or ideally we would be doing monitoring and both compositional and concentration analysis of these particles. But in the limitations of these large studies, I think it's a good tool to kind of just capture the people who do have a meaningful exposure without getting refined about what those exposures might be.
Thank you. Anybody else?
Hi, Lisa, this is Farah. As you know, we've done a lot of vaping type of exposure studies, and I can tell you that the mechanism of inhaling other particulate matter, which is in the form of micelles and things, are very different than the chemical properties of the solid nanoparticulate matter. So I would imagine that what you just mentioned, that yes, there's going to be quite a bit of heterogeneity in exposures in general, but not that to, put one ahead of the others, but they will cause a different havoc, within but the ones they get intercellularly, they would have a different mechanism of action.
This is Paul Handelberger. I had a somewhat different question to run by several of the speakers from this morning and from this afternoon, and that had to do with establishing phenotypes and endotypes of work-related COPD among workers from different industries. And in particular, I was wondering if, to start with a particular speaker, Jacek Mazurek, whether you mentioned the 800 lab tests or tests of one sort or another conducted in Haynes, could those be used to, or have they been used to characterize more details about COPD cases?
Thank you, Paul. The only study that I found was the chromium level, I think the urine or blood level, and COPD. I have specifically mentioned that part because it's over 800 of the different lab tests, based on urine or blood level of various, chemicals and elements that can be actually studied. And I'm not aware of any study looking, other than that, I mentioned in my talk. But of course, expanding the search, the lead search, might identify something, that has been done. I wanted to point out that actually, the difficulty with enhance is the limited ascertainment. So all this is for the hypothesis generating, but enhance is really unique data set, and it allows to cross-examine variety of lab results, depending on the hypothesis.
Has anybody used those samples to look? Because I know there was some discussion yesterday of not really having biomarkers of exposure of occupational exposures. Has anybody looked at those samples to try to identify biomarkers of exposure?
We have, and again, it's a specific context with these controlled human exposure studies, but I think there is something interesting that I would share about that we haven't published, and it relates to particles and macrophages. And of course, there was this New England Journal paper called Carney ways back, and honestly, I was kind of like, wow, New England Journal just show that macrophages have carbon in them. It was kind of a bit surprising to me, but I have to admit it's proven, maybe more important than I realized as a biomarker for some studies. But in our hands, one of the problems is that I think these macrophages laden with particles are a model of chronic, or a marker of chronic exposure, and we were trying to identify our acute exposure changing the amount of carbon in these macrophages, and it didn't, which was a disappointment. But I think it went to prove, or at least suggest, that what you see in macrophages in terms of carbon is really a long-term marker rather than a short-term one. Just kind of an interesting observation.
I was wondering, and now, thanks for mentioning your unpublished result, which definitely help us connect with Dr. Karen Mann presented this morning. Would it be not just the carbon burden, but the morphology, the location, the translocation into mitochondria? I mean, would that be closer to a biomarker? I don't know. I'm just thinking as Dr.
I mean, I'll let her answer, but again, I'm a little bit at risk of talking about something I haven't studied in detail, but I think these particles are transformed considerably between the air we breathe and what we see in these cells. So I sometimes worry about sort of looking at the cells and thinking that we're seeing, exactly what people inhaled. But maybe that's just sort of a nuance that's not worth, debating. I'm interested in what other people think about this whole biomarker idea. And I guess the only thing that makes it, we find these interesting things, but on the practical level, as far as, kind of really moving the ball forward, what I think what we have to think about is it practical? Are we talking about getting induced sputum? Are we talking about, because it's not really something in the blood. And really, it has to be better than the questionnaires. Laura made the point, and others, that these questionnaires are kind of, by necessity, need to be simplified so we can, not be ridiculous about what we're asking people to answer, but then they're crude. And so where's the balance between, a simple question and something where you have to have someone come in and give sputum, as far as the precision of these and how much additional information are we getting by sputum, for example.
And also getting back to, Ravi Kalhan's point, though, about the good biomarker being simple to do, like cholesterol. Unfortunately, induced sputum is not that simple to do. So I wondered, Ravi, what are your top contenders for the biomarker that's going to be the cholesterol for chronic lung disease?
Thanks for that question, George. I mean, I think this really mandates a discovery approach, right? I don't think we have an obvious biomarker largely for the reasons Chris just articulated, is that the ease of accessing the respiratory compartment has made this challenging. And a lot of our work has focused on trying to access the respiratory compartment. There's a lot of promising information that perhaps the nasal gene expression reflects a host response that is recapitulated in the lower airway. We're pretty interested in seeing if we can figure that out in the lung health cohort. By collecting nasal samples and assessing that stuff. But I think, this intersection between the exposure and the host response to an exposure is really, where we have to put our money if we're going to think about it in the context of impaired respiratory health and cholesterol. A surrogate for the questionnaire that's more robust, as Chris articulated, seems pretty hard to me in the context of doing an epi study.
Short of doing that, and and just because we haven't commented on that through the 4 sessions, I had some I wanted to hear what people have gathered so far from quantitative CT imaging when it's specifically applied to environmental and occupational exposures. My sense, and that from not a comprehensive reading of the literature, which is overdue to me, it was that there was less emphysema and more proximal airway changes, which would make sense in some sense, but I don't know if that's the picture, and also if there are plans to corroborate those findings or establish them better through the studies that are ongoing or that are in the offing planning. Any sense of where we are, where we go with that? Because I see in some of the studies that there are plans for actually doing that, but I don't know what the sense is, where we are at this point with that.
Yeah, I agree with you, Raphael, and I agree with you that my reading is also overdue, but I agree with you that there is this general sense that it's more of an airways predominant phenotype. But I think that sometimes that's been assumed and not documented. Similarly, there was this notion that people who have sustained low lung function throughout their life probably have an airways predominant phenotype, but then lo and behold, we found that it has equal amounts of emphysema to people who have accelerated decline in lung function. So I'm not sure that we actually know anything about that. In the LHC, we've really hung our hat on CT trajectories as part of the answer here. That, doing spirometry over and over again is good, but it's not enough. And we're going to have to sort of understand how local injury evolves to different structural phenotypes, including, fibrosis, which has been, de-emphasized by a lot of us, but is probably pretty important and needs to be thought through sort of through an evolution of disease manner, not just sort of what the endpoint is.
Yes.
Just
Laura,
a
do you have-
point in,
go ahead. Yeah.
I just wanted to add with the spiromics data for cross-sectional, we found that the higher risk jobs were associated with higher emphysema and small airways disease on quantitative CT, but that was just cross-sectional. And that was the same for ozone in our spiromics air. So we did see kind of a mixed phenotype on that, but I know that we're hoping to look longitudinally to try to answer disease progression.
But the emphysema was like what percentage of the lung volume
was around like 1 to 2%, so not a huge difference.
Exactly, because in the World Trade Center, for example, COPD gene doesn't consider, it is evolving, but generally when I first asked them, what are you considering, kind of a good cutoff for, the attenuation volume percent, and they said, oh, for us, it's 5%. Well, if we did that for the World Trade Center cohort, we would find like almost nobody. So we had to actually reduce it. And we actually use data from spiromics. or was it from MESA? Either one, that had a little bit of more mixed population, because we do have non-white populations, considerable proportion. So, we have to be mindful of that, and the variable smoking rates, and eventually had to lower it a little bit. And yeah, we used 2.5%, and that was about 10% of the population. And this was a middle-aged, occupationally exposed population, and besides the disaster. So, but the other thing is that we have been careful not to use longitudinal analysis, because so far what we hear from COPD gene is that they haven't been particularly lucky with longitudinal analysis of CT imaging. But again, Laura, what have you heard on your side?
I know we're starting to look at it for spiromics air in particular, because we have such different degrees of averaging time of the exposures and repeated measures. So we're in the middle of that right now. I know we're looking at lung function. So I'm hoping that CT phenotypes are next.
Yeah.
Of course, the same goes with lung function measurements, right? It can be tough to see longitudinal signals in decline in lung function, because of just variability. Every time you measure something, you measure it with variability and with error. And so then if you measure a couple of measurements a few years apart, there just may not be enough signal to noise ratio to see something. So for example, I think, Ravi, in your talk, I think you pointed out that, CRP is associated with low lung function. That's basically, we've seen that at Framingham, people have seen it in other studies. But if you look at the relationship of plasma CRP to longitudinal change in pulmonary function, you don't see it. And I think it can be sometimes, just for reasons for signal to noise, tougher to see things in longitudinal change analyses compared to cross-sectional.
I think we did see it in a cardia paper that I wrote once, George, CRP and lung function, but I only remember that because it was the first paper I wrote when I was a fellow. But I guess you didn't read it, George. But the other thing is, right, we get caught up in population cohort studies on the effect sizes of lung function decline and get very hung up on the fact that this isn't a so-called meaningful effect. And it really has hindered our field in the longitudinal sense, that small declines in lung function in a population cohort are probably quite meaningful in a way that we don't give them credit for when you balance them sort of across the impacts to the population of a small but significant decline in lung function. That's a little soapboxy of me, but having gotten many papers rejected because of a not that meaningful decline in lung function in a population study of non-smokers, it's probably pretty meaningful and we should pay more attention to it.
Mm-hmm, mm-hmm.
This is Paul Henneberger. I think Dr. Blanc showed some data yesterday where the lung function declines associated with different exposures, longitudinal declines, were less than that associated with the smoking declines, associated declines in the same population, but still substantial. And so, in other words, by using a cohort that had both smokers and non-smokers and people exposed to occupational exposures and not exposed, they were able to show that these what indeed seemed like small declines were still meaningful when you considered how they compared to what was happening in association with smoking.
Oh, that's definitely, so that's a great point, Paul. And as Ravi was saying, if in a population, the excess decline associated with smoking in a population is, let's say 20 mLs per year, excess, or 30 mLs per year. Well, if you see some other exposure that's associated with 10 mLs per year excess decline, and it's real, and you say, well, gee, that's half or a third of the effect of smoking. That sounds quite substantial and quite significant. The challenge can be sometimes whether it's a statistically significant effect. You need a large sample size to show that.
Now, you refer to the issue of these cohorts that that were described this afternoon are using longitudinal spirometry, and Are you adopting the revised, more stringent ATS in guidelines with regards to end of test volume? At the World Trade Center program, we have 20 years of flagellation trying to adhere to the best possible quality in spirometry, and it's always a challenge. The larger the number of people you have, of course, and the larger the shorter intervals between spirometers, because you are doing many more. So, what are your thoughts about that? And are you fine with that? That could be a very short answer from both of you in rural and lung health.
Ravi, you want to go ahead?
Raphael, I have found that 25 to 35-year-olds, end of test criteria are giving me chest pain in the lung health cohort.
Mm-hmm.
Because it is very, very hard for healthy young adults to achieve the end of test criteria. So we are, this is a terrible answer. We're basically doing our best with end of test criteria.
Hey.
But it's sort of...
All right, George, please.
Yeah, same for us in rural, because, I think you don't want to let perfect be the enemy of good. And so, we look at every spirometry that's done as part of our QC program. And, if we have one that's a little shy of 6 seconds, but looks like a perfect plateau and very reproducible, it's just not quite 6 seconds, we will sometimes upgrade and say, that's quality spirometry. It didn't quite make 6 seconds, but it's a really nice plateau. And then, of course, we all know people with airflow obstruction may blow up for 12 seconds and never reach a plateau, and that's also acceptable spirometry. So we take a sort of a stringent QC approach, but one that really involves looking at the curves and looking at the tracings and trying to make a judgment if it's good quality usable spirometry.
Now, I have to make this comment before we run out of time, and Lisa, I hope she's not looking at me. So, but we find in the World Trade Center cohorts that bronchodilator response, however we find it, which may be cause or effect, right? Is actually quite important for lung health, and we are not the first to show that. It's been shown. I think Antonison had shown that, but I don't know. I think it's all information. So how? I mean, do you think you can afford rural and lung health to do without it?
Well, we're doing it in rural. We are doing it, but we are finding the following: about as many as half or so of the participants who are eligible to do it because their baseline study is low decline to do it, and it's because it's a pulmonary function testing is not the whole protocol. They're doing CT scans and echoes. It's a long test day. They get to the point where, there's someone who's never used bronchodilators. So now we want to give you this medicine, and sometimes people will just decline to do it.
Yeah.
So I don't know, in our latest numbers, we started out like around half of the eligible people declining to do it. I have to see I think we might have gotten a little bit better than that lately. We may be 2/3 of the eligible people doing it, but it raises issues, and some of those issues are why Ravi and his group decided not to implement it.
Yeah, we decided not to do it at all, Raphael, mostly because of burden and just we couldn't fit it in. The idea of getting these young adults in for a visit is hard to begin with. But,
yeah,
and I'll be interested to talk to you more, Raphael, because I did do it in my ancillary study to Cardia at the year 30 Cardia exam. We gave albuterol to everybody, and the results were completely non-informative. And maybe we're not looking at it in an appropriate context. So I would be really, I'll talk to you offline about it, but there probably are things we could do in that context to make a better understanding in Cardia, at least, about bronchodilator response.
And short question: are you going to be using GLI or and for bronchodilator response a predicted of the a percentage of the predicted and not of the actual change of the baseline? The guidelines keep changing.
We're fortunate that we haven't had to make that decision yet.
Okay, George, please.
Well, we're just still the baseline exam. You know, a subsequent follow-up spirometry will be for a future grant, you know, refunding. So we don't have a follow-up visit as part of the currently funded protocol.
Great.
All right, we are out of time, but I want to give the speakers just one chance. If you have a question for each other, and first come, first serve, and then we're going to have to end this. So does anybody have a question for their fellow speakers?
Well, maybe I'll start, if I may, to actually the other three speakers. You know, should we be pushing our studies to add more occupational history questions? I tried when we started rural, and there was just so much on the table that my suggestions for this comprehensive NHANES-like questionnaire wound up on the cutting room floor. I'm wondering if we need to make a push as the studies are getting underway, or in the case of spiromics and COPD gene continuing, to push for more detailed, comprehensive occupational histories.
I think that in the ideal world, that would be great. And as you mentioned, like an ancillary study would be perfect. But I do think that a low-hanging fruit could be adding the longest job VGDF question, even though it's not perfect and it's not telling us details about mechanisms or certain types of exposures, but it really does line up well with the GEM. And I think it would add a lot of value to all of these cohorts. I mean, we use it as a covariate in spiromics, pretty much all of our analyses now, and it's simple. It's very easy for a participant to answer and doesn't add much burden. So I think if like a low bar would be to include that on all of these cohorts, and then from there we can talk about adding more detailed exposure questions.
This is Jacek, and I would second what Dr. Pauling just said. And in the chat, we included a link to the NIOSH tool that is assisting researchers in collecting and coding information. Then would be in a systematic way, and it's fairly easy to use. So I invite you to explore that link that's in the chat. Thank you.
Okay, well, with that, with 3 minutes over, I want to thank everybody, thank the speakers, both from this morning and this afternoon. Really informative day of talks. And I want to thank those of you who have stayed with us and listened, and those who will listen to us in the future when this is online. And again, the information is in the chat on how to get CME credits for this. And I will just ask Paul if there's anything else that he wants to add.
No, I have nothing else to add. Just thanks to all the speakers today, and thanks for such great presentations and great discussion. It's much appreciated.